Good afternoon, everyone, and welcome to the national webinar, Asking about FGMC in Healthcare Practice. Before we begin today, I would like to acknowledge the traditional custodians of the lands in which we are all meeting today. I am joining you from Wurundjeri country of the Kulin Nation, and I pay my respect to elders past and present. I also extend that respect to any Aboriginal and Torres Strait Islander people joining us today. I reflect on the leadership of First Nation women and their ongoing advocacy in women's health, and recognise the importance of listening to their voices, knowledge and expertise to achieve health equity for all of us. I'd also like to take a moment to acknowledge the women and girls affected by FGMC, those with lived experience who continue to navigate healthcare systems with strength and resilience. We acknowledge the advocates, survivors, community leaders, and health professionals, many of whom who are migrant and refugee women themselves, who continue to work tirelessly within their communities and services to prevent this practice and improve support for women and girls. Their leadership, courage, and advocacy continue to shape this work in meaningful ways. My name is Nasra Musa. I will be hosting today's webinar, and I am a capacity building officer at the Multicultural Centre for Women's Health. That's where I lead initiatives aimed at strengthening the health workforce's responses to female genital mutilation and cutting, or FGMC, in Australia. For those who are unfamiliar with our organisation, MCWH is a national community-led organisation advocating for the health and well-being of migrant and refugee women, particularly in the areas of community engagement, workforce development, health promotion, research, and advocacy. The webinar today is being delivered through the SWIFT project. It's a national initiative led by MCWH that supports health workers across Australia to strengthen their knowledge, confidence, and practice in preventing and responding to FGMC. Through our training resources and also establishing a national community of practice, SWIFT aims to strengthen the workforce's capability and improve healthcare responses for women and girls affected by FGMC. So thank you all for joining us today and for your interest and commitment to strengthening healthcare responses for women and girls affected by FGMC. Before we move into the presentations today, I just wanted to go over a few housekeeping notes. So firstly, the webinar today will be recorded and will be shared through our SWIFT network and MCWH's resource platforms as an ongoing workforce development resource. All participants who are joining us today will remain muted throughout the session. However, you can post questions throughout the webinar in the Zoom chat, and we'll address as many questions during the Q&A session toward the end of today's program, or in follow-up after the webinar concludes. Importantly to note that your questions will be private and only submitted to the webinar organisers and our wonderful panellists and guest speakers. We are incredibly grateful to our guest speakers for joining us today and sharing their expertise across advocacy, community engagement, and clinical practice. So without further ado, and to officially begin our session, I am honoured to introduce our first guest speaker, the Honourable Juliana Nkrumah. Juliana is the Acting Head of Women and Gender Equity at Settlement Services International and the recipient of the 2023 Australian Human Rights Medal. And this is in recognition of her more than 30 years' work advancing women's rights, refugee and migrant empowerment, gender equality, and social justice in Australia and internationally. Juliana holds a master's degree in sociology and social anthropology and is a passionate advocate, public speaker, trainer, and facilitator. Juliana is an acclaimed leader in the FGMC prevention space in Australia. She established the New South Wales Education Program on FGM and the network of FGM workers. Today, Juliana will help set the context for our discussion and explore why asking about FGMC really matters, including the lived realities of women and girls, the barriers to disclosure, and also what our FGMC responses look like in Australia compared to internationally. So, Juliana, thank you again for being with us today. And I'll now hand over to you.
Thank you, Intesar. Thank you very much. I would say that the traditional owners of this land have been respected and acknowledged. But as an elder who is also a traditional owner from the country of birth of mine, I would want to say that this country holds a lot of stories. And when we tread on this country, we tread with all the respect that we can bring. Thank you for this opportunity to share with you. And I've got only 25 minutes to share big stories, so let me get on with it. The government of Australia waded into a discussion and an approach to female genital mutilation, then female genital mutilation, today female genital mutilation cutting, from the middle of the 1990s. And we all know historically the situation that led the Australian feminist movement to get into this conversation and debate. At that time, the African women were the people who were deemed to be wicked women, if you like, who were practicing barbaric practices on their children. It was a very dark time for women from African countries, especially those in Victoria, and the government picked it up. The good thing is we had the Federal Law Council report, and from the Federal Law Council report, we had a lot of recommendations, including two obvious recommendations, which were to have a law in Australia that prohibits the practice of female genital mutilation, and also to have community education. So when they talked about community education, they wanted community education for the community prior to the passing of the laws. But before the community did understand what the position of the government, the law had been passed already, especially starting in New South Wales in September 1994. So came the community education. I think that at that time, the government thought this community education was going to take like a couple of years and it was okay. But we turned it into one that was based in community development so that the communities themselves would be brought along to the point of ownership. If you do community development, you will understand how important that we need to get the buy-in from the communities to do that. So that is the storytelling. This process reflected the issue of bringing the global to the local in Australia. And in this situation, it was bringing the global policies and the global decisions that had been made into the local in relation to child safety declarations. So in my sector that I'm working in now on gender-based violence and women's gender equality, the sector, the settlement sector, is currently looking at having a deep discussion about how do we bring the global policies back from the meetings like the Commission on the Status of Women, Women Delivered that's recently happened in Melbourne, into the local. So we are looking at seeking to gain strategies for working with female genital mutilation with women in diaspora. Now, that itself holds a whole heap of issues that we still haven't been able to debate deeply. And remember, on the back of all that is colonization and the disruptions that colonization has caused in countries and even in resettlement in Australia. So in 1995, female genital mutilation was discussed and considered and debated as a women's health issue. And this is what makes it interesting that today we're looking at how we deal with female mutilation in health, in delivery of women's health. This is what has prompted a situation of the female genital mutilation program in Australia within women's health. It was easier. So we had 2 prongs. We started off with 2 prongs, and I think Australia is continuing to hold on to 2 prongs: community education and professional education. Professional education because of the realization that women survivors or victims or women affected, we're still working on the language on that, had long-term effects from the practice of female circumcision. And these were known and seen and confronted in pregnancy, childbirth, and other forms of care for women's health. But not only that, there was a need to support women in navigating these medical spaces that are mainly different and foreign, and that the spaces where Hio in the, I borrow from you, Nazra, Hio in the Somali parlance was not there anymore. So when Hio is there, we are comfortable. But when Hio is not there, Hio as in grandmother, the role of grandmother in women's health. When Hio is not there, you are not comfortable. And you tend to, that discomfort leads you to other psychological spaces. So the Clever FARREP program, for which I give all the kudos to my friend Maskapi Sejoy, is another way of getting the community the support that they need to navigate the women's health system that is foreign and totally different. The community education was based on the belief that community needed to understand the government's position on the role of FGM, especially the role of the law and child protection. Today, we meet to continue working with health professionals, still grappling with how do we assist with health conditions that was not part of our training curriculum. In the past, we sought to help doctors. So we went into the community and we sought for doctors who had experience and gynecologists who had experience of dealing with women who had been circumcised in their country of birth, who live in Australia, some of who are not even practicing as doctors, to share their knowledge. And then we're able to bring that sharing of knowledge to different hospitals and different areas in Australia where there were cohorts of women circumcised who were attending these hospitals. And we also worked with RANSCOG to be able to input information on female genital mutilation into the curriculum. This has helped to prevent those mistakes, those very serious mistakes that one is not able to share because one only carries the impact and the impost of those mistakes that are carried by the women of experience, and the women of experience are not here to share. However, let me note for us that we have made some mistakes in the past, and they have had very serious implications for women who are already circumcised and already traumatized from their circumcision and trusting the system to support them. For the purpose of those mistakes, we are here today so that we don't repeat those mistakes at all. And the law. The law, is based in the criminal code. And today we are not discussing the law because you are not frontline workers, you are not social workers. But that is the space in which we discuss the law. The law was one that we brought in frantically, and it was required action to calm the community. We've got a law on FGM, so it's okay. Now, the law has implications for child protection. We understand that. What does the law mean for a woman in diaspora? That's a conversation with the community. So there are different prongs of the work we do on female genital mutilation. Today, we are looking at one prong, and we'll dive into it further. The information I'm bringing you is to back your understanding and influence your approach to the work you do as a clinician. Take it from me, I'm not a clinician, and really, I respect all clinicians for the work they do, and I'm coming here because I want to give you extra information to back your work so that at the end of the day, you're able to center the woman properly. Nazra, please give me 5 minutes notice, okay? As we, the old guard of FGMC, worked through the process to establish how Australia would deal with this situation, we moved on trusting that some of the people we had worked with and trained were able to carry the load along. As we did that, the world outside Australia changed, and the world has changed very quickly. Today, the world has changed from the focus on women's health more onto the focus of two: one, human rights, and two, gender-based violence. So when you look at the Beijing Platform for Action 1995, which is the current document upon which we look at gender equality globally, and you would see that through the way the Beijing Platform for Action continues to be the document that is used on the Commission on the Status of Women, there are 4 spaces in which FGMC was highlighted: women's health and violence, which is violence against women; women and health, the girl child, and the human rights of women. Now, these continue to operate, and the society out there has moved on so far away from where we sit in Australia. Why do we say that? The Beijing Platform for Action, in all that, stated clearly that cultural and traditional practices inimical to the health and welfare of women and girls, specifically female genital mutilation, was a priority area to look at. Today, the changes have come in a whole heap of areas. Women's health is acceptable, but human rights and the rights of the girl child, and also looking at the whole issue of human rights is very important. Now, when I've sat down and done my analysis of how female genital mutilation as one practice violates the human rights of a woman and a child, I came up with 10 areas, 10 points of violation. Then we look at research that is today abounding around data to justify the action. The emergence of state and national programs based on human rights, gender-based violence, and community-led work around female genital mutilation has taken a very high position internationally. And in Australia, we're still sitting where we've been sitting, looking at FGM right from the area of women's rights, women's health. These movements, the global movements, focus on the rights of the child and focus through research and data collection so that more communities have been identified. I want to say that in Australia for a very long time, and I would not be incorrect to say today that in Australia, female genital mutilation cutting continues to have the face of the African person, the African woman. This debate is old. It cannot continue to wear the face of the African. Because as much as when we started work in 1990s, it was based on what happens on the continent of Africa, to the dismissal probably of what happens in other parts of the world. The world has grown today to realize that it is not happening in parts of 31 countries on the continent of Africa anymore. However, it is a global practice. I will give you a quote from the UNFPA. The UNFPA says female genital mutilation is a transnational public health, human rights, and gender injustice issue. It has devastating impact on girls, women, men, and communities. That's not all. You know that there are more impacts on that. But I also want to let you know that the trend is moved around language. And that is very important for you as a health worker. Language, including cutting, thank you, oh my God. Language, including cutting, was one that has come into the conversation because communities were affronted by the word mutilation. So in Australia, with the community, we use female circumcision. There's a whole debate around that one too. The human rights analysis of the practice indicates that there's violation of a lot of the human rights actions and practices. So these movements are working very much on data collection, and we've moved from 31 countries on the continent of Africa on to 94 countries around the world, hence the position of the UNFPA. Australia needs to get with the global trend, and that is the message that Multicultural Center for Women's Health is talking about. We need to center women as health workers. When a woman comes in front of you, it's really important to talk about, to talk to the woman about what practices happens in some countries so that you can ask the question about, have you had any cutting? Now, in the 90s, we worked with the Urban Hospital and we set up tools for assessment, and we input female genital mutilation into the midwife's assessment tool that was existing in the hospital. What could we do? That's what existed. So in the midwife's assessment tool, you ask the questions about what operations have you had, including female circumcision, even though on the paper it's female genital mutilation. That gives you the opportunity to then send the person off to the midwife's clinic. Young women with lived experience in diaspora are leading the chase globally. So it's important that in Australia, we open up to involving the voices and the understanding and the skills and the capacity of young women from communities that are affected. We need to, when we talk to clinicians, we need to bring respect to the situation. We need to probably work with women who are heroes, grandmothers in the community, because they hold the tradition and they understand more how to deal with the community. And so I send you back to the FARREP women as secondary consultants in the program in Melbourne. Take care in asking, acknowledging communities practice cutting. Would like you to ask, have you experienced cutting? Or if you know the cultural name, Bondo, Sunday, Gunin, Kritan, ask so that the person will feel comfortable in working with you. Asking a woman a general question and then bringing in the question on cutting is very important. The question then is, what was cut? That's not a question, because a woman will not know what was cut. And this is where you can have a conversation with your, whatever practices you have in your hospital, show, or using photographs to show the woman, look, I'm going to show you a photo. This is the normal vulva. This is what is cut in certain places. And I want to inspect and find out for myself what is cut so we can give you the proper support that you require. Let me bring to you that 94 countries are beyond the countries in Africa. Increasingly, we find a lot of countries in the Middle East and in Asia, in South Asia. There is the language that says our type of FGM is just ceremonial. It's not like theirs. That is a language that brings discrimination. We don't want that in the space. We can't afford that in the movement. It's important to understand that World Health Organization has clearly stated all forms of female genital mutilation are, all forms of cutting are female genital mutilation and cannot be condoned. So we cannot join the language that says, oh, Diaz is ceremonial and Diaz is dangerous. We can't do that. That's where we end it. Nazra, I will end here and I'll wait for questions. Thank you very much, everybody.
Thank you so much, Juliana. Such a thought-provoking talk. I think what stands out for me is just the positioning that you gave around FGMC globally in the context of human rights, but also where we're falling behind in Australia and our very narrow view of looking at FGMC as an African issue. But also you reflected a lot on the importance of women's leadership in this space and the importance of community engagement as well. And how centering women's voices and experience is actually how we're going to start to create change. Also, you gave a good segue around, FARREP workers and the importance of having bicultural workers. So FARREP, people here might not know, it's the Family and Reproductive Rights Program that operates in Victoria. And I think that's a good segue for me to introduce our next guest speaker, Intesar Homed. Intesar is an experienced health promotion and community development practitioner with over 15 years experience supporting culturally, linguistically diverse migrant and refugee communities across Melbourne. She currently works at Mercy Hospital as the coordinator of the African liaison, as an African liaison officer, and also in the FARREP program as a FARREP officer. And there she leads engagement with women and also strengthens access to sexually reproductive health services across the Mercy Health Network. She has qualifications in counselling, community development, children's services, applied science. Do you want to study any more into stuff? But she does bring, because of that, she brings a multidisciplinary lens into her work. And she's very deeply committed into advancing equity, cultural safety, and meaningful community participation. Today, Intesar will share with us her practice-based insights from FARREP, as well as Mercy Health's work, and she's going to reflect on what actually builds and breaks women's trust in navigating healthcare settings, and the importance of FARREP workers in being able to engage sensitively with women that have lived experience of FGM. So I will hand over to you, Intesar.
So thank you so much for the introduction, Nasra, and thank you, MCWH, for giving me the opportunity to talk today about FARREP. I've been in this sector for so long, as Nasra said. So today, would you like to share my slides, Faye? Thank you so much. Yep, so today I'm going to talk about, I'm working currently as FARREP worker or African Liaison Officer at Mercy Hospital. I would also, before I start my presentation, I would like to acknowledge the traditional owners of the land on which we're meeting today. Pay my respect to elders past and present. Okay, would you go to the next slide, please? Yep. Go to the next one. So, FARREP at Mercy Hospital. So, as Mercy Hospital, we are two FARREP workers. So, one based at Werribee and myself based here at Heidelberg. So, as FARREP workers, we play a critical role in bridging the gaps between women, communities, and health services or health system. Help women understand how Australia's health system works, what to expect during appointment, and what their rights are. We also do, sorry. So we also do, we provide the services one-to-one kind of support, especially here at the hospital work. As Juliana said, like we bring the woman into the office and explain to them our services here at Women's Health at Mercy Hospital. So the support includes emotional support, information about health impact, and guidance on available medical or social work or allied health, other allied health or other services like family violence and stuff. The aim is to ensure women feel safe, respected. As Juliana said, that's the main thing. That's what I hear from women. Respect and understanding from health professionals. And I'm 100% sure this is what the health professionals doing as well. I also do capacity building. So I train health professionals and allied health here at the hospital about the social and cultural aspect of FGC. And that's how to respond sensitively. This improves the quality of care and reduce stigma or misunderstanding in clinician settings. We also work closely with community leaders, organizations, and culture groups across Victoria. Those kind of engagement help spread the awareness, reduce misinformation, and strengthen prevention efforts. We also promote understanding of FGC. And you hear me say FGC all the time because this is what I believe. I know it's a bad practice that we need to stop and we need to eliminate. And, we do all we can do to stop this practice happening to young girls. But as from that community, I don't feel I'm mutilated. So, and this is what I want you guys, when you work with a woman, to use, as Juliana said, cutting or circumcision. So we do the FARREP program through partnership with school, health services, community groups, and government agencies. Awareness activities, those awareness activities help normalizing the conversation and encouraging early support seeking. We also provide secondary consultation at both hospitals. So if health professional comes across a woman that being circumcised or cut, they can come and ask us for help or assist them to work with the women. Seek advice on how to support women experience FGC. This is strengthen clinical pathways and ensure women receive appropriate care. We also ensure services are tailored to the needs of women for communities where FGC is practiced. This includes respectful communication, understanding cultural sensitivities, and offering holistic support. Please go to the next slide. Thank you, Faye. So this is the stuff that we do with the women when they arrive to our antenatal care. So we do our work at the outpatient here at Mercy Hospital, Heidelberg. So we help the woman understand their maternity care, options during pregnancy and before birth. This includes explaining procedures, appointments, and what to expect in a way that is clear, respectful, and culturally safe. So women can make informed decisions about their care. I will also attend clinical consultation, and that depends on the woman if she wants us to do that when they discussing FGC, to emphasize the supportive role, being present to help women feel safe, heard, understood, especially during sensitive conversation that might cause fear, confusion, or distress. For example, like a woman, she's type 3. I'm not here to discuss types today, but female genital mutilation is being classified to 4 types, and that comes straight from World Health Organization. And type 3 is the severe type. So especially those ones, they might do like the infiltration, which is reverse the procedure before labor and stuff like that. We also offer cultural guidance to clinicians. This helps clinicians better understand a woman's cultural background, beliefs, and experience. So here, we don't, as Juliana said, we're not teaching what the health professional does, but we just come in from, cultural kind of beliefs and experience just to support the health professionals understand that. We also support communication between the woman, the family, and health professionals if the woman wishes it, if she wants us to do that. This might include clarification. So, if she wants us to clarify anything with the health professionals, reducing misunderstanding and helping all parties communicate in a respectful and culturally safe way. We also connect women with additional services that support their overall kind of well-being. Those might include social work, physiotherapy, dietitian, diabetic educator, and all these things show care goes beyond pregnancy alone and address both the health and social needs. Because those women, You know, you cannot just work with them, just FGC, because it's as a holistic health profession, as health, general health with those women, well-being, physical, everything, you know. So we're not just gonna work with them as FGC practiced women or experience. And also use always the word experience, not affected, because I don't feel affected as well. So we assist women to express questions, worries, or concern that might find difficult to arise themselves. This includes helping women communicate those concerns appropriately to help staff so their voices are included in care planning. We also provide education about FGC, including health impact and Australian legal and healthcare. So we kind of work in the middle of, like, you know, between the health professionals and the women. The women to get all culturally appropriate services, and for the health professionals knowing how to work with those women. We also strengthen relationship between African communities and the hospital. This builds trust, improve engagement with health services, and support better health outcomes for women and families. We also advocate for culturally safe, respectful, and person-centered care. Make clear that advocacy work alongside, not against, clinical process, ensuring women's cultural needs are respected while maintaining high quality medical care. Please go to the next slide, please. So I'm just going to give you like a few seconds to read this case study. So as you see, this is a case study straight from the Medicine Hospital. A woman came to antenatal clinic feeling anxious. You know, she's type 3. She was young. First baby. She's been here in Australia. Maybe this is not state here, but she's been here very little time. So she came with marriage visa. So she was very anxious, and, you know, she was saying like, how I'm going to talk to the health professionals, what's going to happen. So this is where the FARREP program come, an African liaison officer here. So we play a vital role in supporting women affected by experience by FGC, creating a safe, respectful, and culturally informed healthcare experience. So as Juliana said, so I'll go to the woman, to the outpatient clinic. You know, I speak to them. I say, I'm Esther, I'm the FARREP worker. So, you know, I'll be very relaxed, very welcoming. And then I might invite them to my office. So I've got my office here because it's like private kind of space that the women feel comfortable to talk about FGC, especially type 3, because as I said, it's a very severe one. And not just this one. So there's many women experience anxiety during pregnancy, medical appointments. So, you know, even though you don't have, you know, you're not circumcised, you still have those kind of questions when you're pregnant, especially with your first baby, and you'll be like in your 20s, like 21 or 19. I think she was around 19, this girl. And childbirth due to past trauma, fear of pain, uncertainty about procedure. All those concerns about being judged as well. Like, you know, I'm here in Australia now. You know, they do like circumcision, maybe not. Maybe it's a new thing for the doctor to talk about. You know, all those kind of concern that comes to the woman. So FARREP also come along here and reduce those fear. So I bring the woman to the office, talk to them. As Juliana said, I've got photos here to show them which one is that similar. So I've got type 1, type 2, type 3 photos, big posters. And then from there, I will know what type they are. And also if they want me to go and, to the midwife or doctors that they're going to see on that day, I'll come along during the consultation, as I said. So our job is here also to explain clearly, what women, know what will happen during appointment and press. So there, the doctor gonna examine you and see what type are you. So even though she tells you this is the type, but we need to examine and see what type she is. Like we give her all the options. Like you can do de-infibulation if type 3, especially before labor. All those kind of things. So I'll explain to her here before she goes to the doctor. So when she goes to the doctor, she will feel more comfortable to talk to or midwife or nurses, whoever she's seeing at that time. I use simple language and to help with her communication, to talk to the doctor, to talk to her. So I'll be somewhere in between. Give emotional support, and this is very important. Like understanding, I know what you're going through. I understand what you're anxious for. Things like that. So emotional support, so women feel calmer and more confident. Advocate for women to make sure their privacy, dignity, and choices are respected. Providing a clear information about the law so women understand their rights and feel reassured. And also, if the baby gonna be female, a baby girl, so she need to know what's the legal status here in Victoria, especially. And you tell her in all Australia is prohibited. Even if you go back home, you go everywhere, it's illegal. So you will explain to her the illegality. Thank you, Nasra. I'm nearly there. So this helped the woman be involved also in decision when you explain to her her rights about their own care. As a FARREP worker or the coordinator of African Liaison Officer here at Mental Hospital, we do like a survey every year, once a year, but this communication is ongoing as well with the women that I work. So I will ask them what you want us to do, what more, what less, how we want you to serve. So we want the women to be confident and also spread the services, because it's oral kind of in our culture. A lot of, if you want to give a news or you want the news to spread this by mouth. So we just let the woman knows that we're here to help them so they can, pass it on to people that need the services. So I will ask the woman all the time, and then I said, what you want us to do, and what the health professional want them to do, and then they will just say, we just want to be respected, to be kind to us, clear explanation, privacy, and no judgment. That's all the main kind of things that women ask. To be treated as a whole people. It's not like just only someone with FGC. So we need to look, as a whole kind of person, what they need from the hospital. So FARREP come along as well and helps make this possible by building trust, reducing fear, and making sure women feel safe and supported throughout the healthcare journey. Probably this is all from me. Thank you so much. I wait for questions.
Thank you so much, Intesar. Thank you especially for your reflections on reflecting on the important work of FARREP in Victoria and helping women navigate the health system. Hopefully one day programs like FARREP will be more consistently embedded across Australia. But I think at the same time, the existence of FARREP in Victoria, it doesn't remove the responsibility for the broader health workforce to actually ask about FGMC. All health professionals still have a role to play in confidently asking about FGMC appropriately and respectfully within their own practice. But there's a lot of strategies that you provided even within your FARREP work that can be embedded across the health system. For example, the importance of setting up a safe and private space to actually have those conversations with women, the importance of providing comprehensive information, including about the law, when it's safe and appropriate to do so. So I think there's a lot that we can learn from FARREP work in general. But just in the interest of time, I might now move on to our final presentation for today. So I wanted to introduce Monica Diaz. So Monica is an advanced midwife and nurse consultant with over 25 years of experience across clinical practice, research, education, and health system leadership. She's a Winston Churchill Fellow, awarded for her international investigation into models of maternity care for women who have experienced FGMC. Monica is a PhD candidate researching on the South Australian FGMC education program, the SAFE program, which many of you may have heard of already. It's a co-designed evidence-based workforce education initiative that integrates research evidence, lived experience, and clinical application focusing on culturally safe, trauma-informed care. She is also a co-founder of the Australian FGMC Support Network for Healthcare Providers and has contributed internationally as an Australian representative to the WHO Guideline Development Group, which is a big win for us to have Monica representing us from Australia in those guidelines. Today, Monica will share practical guidance on when and how to actually ask about FGMC in clinical practice settings. I will hand over to you now, Monica.
Thank you so much. I'm just setting it up, and please let me know if you can't see the slide. Is it coming up now? Yep, yes. You can see it. Perfect. Yes. Thank you. Thank you. Thank you so much for that introduction. I've got 20 minutes, so I will try to get through as much information as I can as possible in that time. I normally have these sessions as quite interactive, but we don't have the capacity to do that today. So if you have anything that you want to say or comments or feedback, please put them in the chat, and I'll try to get to them at some point. So we'll get started. So what I want to present to you today is a little bit of what the SAFE program that we have here in South Australia around how to start conversations about FGMC in clinical care. So I'm coming from the point of view of the clinicians. Now, this information has been put together in collaboration with women with lived experience. So this is what the women identified as key things that clinicians needed to understand and what they wanted to have in terms of resources and support. So just to get started, what I wanted to do is, if you have the capacity with using your phone, just click on the QR code and just answer this really simple question. I just want to get an idea of how confident do you feel talking to women about FGMC in clinical practice, and just, it's all anonymous. So I just want to have an idea of where I'm starting at and how I can direct the conversation. So I'll give you a couple of minutes to do that. Okay, so we've got people saying not confident at all. Yep. Beautiful. Thank you so much for everyone who's answering. That's really, really good. So we've got a mix. So most people feel that they're not confident, and you can keep responding to those to that survey. I'll move on to the next one. So we're starting from a place of, we need some more information, some more resources, and some more knowledge to help get through this. So I'll move on to the next slide. Right. So how do we start the conversation? So the first thing is that we need to, as clinicians, we need to understand what the barriers are to conversations. And when I interviewed women and have had these conversations with women here in South Australia, a lot of the time they said they just felt embarrassed. It's a taboo subject within their communities, and sometimes they don't even talk to their own mothers or sisters about it. So it's a very quiet and private thing, and so therefore it makes it difficult to talk to someone you've just met for the first time. Also, it's a women's issue. So when you present to GP or to a hospital and you are greeted by a doctor who's a man or a nurse who's a man, then that conversation is even harder to have. Also, we need to understand that a lot of women have limited English, or English is their second or even third or fourth language. And so sometimes the translation of what the conversations that we're having are not very, do not actually translate. And so we need to be aware that we might need a little bit more time to have conversations and to have appointments with women to allow them that space to be able to think a little bit more and to process the information that we're giving them. Another thing that I found quite interesting earlier on in my research career in this space was that a lot of women didn't know that they had FGMC, and that's for various reasons, including the fact that a lot of women have it when they're quite young. As we know from trauma psychology, that a lot of people block certain events, so it's traumatic events. So a lot of women don't remember, or they don't know that they've had it because it was done so young. So often if that conversation is started, women will say, no, I don't have FGMC. So that's something that we need to be aware of as well. Another thing that's really important, and it's also something that we do as part of our course, is we talk about our understanding our own biases. So we look at culturally safe principles and looking at trauma-informed care and looking at how we as clinicians already have our values and beliefs formed and how that impacts our interactions with community. And that's not just with women with FGMC, but with everyone. Another thing, and it's already been mentioned during this presentations, is the environment. That's really, really important. That's something that I found out when I visited clinics in Europe, was that the environment is really important. Women need to feel that they're safe. Also, like one of the things was, for example, in one of the cities I visited, a woman started to have a panic attack when she was being taken into the treatment room. And on further investigation, it was found out she had medicalized FGMC back in her country, and it was the treatment room that she was taken into to have this procedure. So just the fact that she saw the sign that said treatment room triggered her. And so it's really important that we understand that there's a lot of factors that come into play when we are caring for women with FGMC. And another thing that's really important, and again has already been mentioned previously, is why do we need to know? Why do we need to know that a woman has FGMC? Is it relevant to their care? And I work in the maternity and sexual health space. And so for my clinical care and planning, that can be quite relevant. So it's about determining if the woman is coming into your clinic or coming into your services, what is she actually here for? If it's for a cold or flu, we don't need to know. But if it's something relating to the vulva, or that may be impacted by, if we're doing a pap smear, for example, then we need to understand what we're dealing with. I've just talked about safe environment, building trust and rapport. Women need to, and I think we do that quite well. And that was one of the things that a lot of the women that I talk to have said, that they feel that clinicians here in Australia do that really well, building that rapport and trust. Women also identify that they need time to discuss their health concerns. So those, 15 or 10-minute slots that we put everyone into different appointments may not necessarily work for a woman who has a lot more things to discuss. And also, like I mentioned before, if English is not their first language. Using respectful language, another thing as mentioned. So we know that female genital mutilation is the international standard of how we talk about the procedure. So in policies and guidelines, that's how we refer to it. However, when we're discussing with women in the community, we should be respectful of how they talk about FGMC. So there are various resources, and one of them, it should be coming up. Can you see that? Please let me know if you can't. This is one resource, and I'm happy to share that with you. It's from the National FGM Centre in the UK, and they have different terms depending on the country or region the woman is from. So things like that can be quite useful. So access those resources. Really important. And another thing that women talked about was about body language is universal. So if you already are starting with some kind of bias, or you thinking, oh, like I've never seen FGMC, and then you start reacting, even if you don't have to say anything, women know, women can tell, and they will not continue conversations with you if they feel that they're being judged in any way. So it's really important that we are aware of, you know, how we are interacting with women at all levels. And where possible, please facilitate female healthcare worker providers. As I mentioned before, it's quite a you know, a woman-focused space. It's quite a sensitive subject, and women need to feel that they're comfortable to talk to another woman about it. So just quickly, I know we won't be able to have an interactive thing, but if you can pop some feedback on the chat, we can go through it afterwards. So I'm just going to go through a quick case scenario. This is one of the examples of what we use in the SAFE program. So we have Amina here, who's 25 years old. She's coming with her first pregnancy. She's 11 weeks pregnant. She's actually in the antenatal clinic. It's a first booking visit. She's from Sudan. She came to Australia when she was 16. She speaks fluent English, and she's here on her own. Otherwise, she's a healthy adult, no other issues going on. So during her assessment, she tells you, one of the things she says is that she's finding intercourse quite painful, and she's not sure why. And when you start sort of asking a few more questions about her symptoms, you start thinking that possibly she has FGMC. So I want you to think, we've got a few minutes, how would you approach that discussion? How would you start to ask about FGMC? And what sort of things do you need to keep in mind when you're having these discussions? And I did mention a couple just earlier. So just have a think about it. If you don't want to write anything on the chat, that's fine. Just in your head for a bit, and then we'll move on. Nasra, also, can you tell me when I have 5 minutes left, please? Thank you. Right, so we'll move on to the next slide. So how would I describe? Thank you, 15, perfect. So the first thing is I will ask her. So the first question I normally will start with is, for this assessment, for this history taking, I would like to ask you a few questions that will help us understand your health and cultural needs so that we can care for you better. Is that okay? Just to set the scene. So I'm not straight away starting into FGMC. I am talking about the whole picture. I want to know everything that will impact care. So we'll talk about, and then if she's happy with that, then I'll start with asking her about FGMC. And there are different ways. It depends on how comfortable you feel and the conversation that you're having. If you have a woman who's quite open to answering questions, then I will start. Have you heard of female circumcision? Do you know whether in your community that is practiced? Do you think you have circumcision? And I'm using the language that is, I'm not, as you can see, I'm not using FGM, female genital mutilation, because that's quite confronting. I'm using circumcision. And women have different terms. So some women call it cutting, some women call it circumcision. Some of the women that I spoke to called it pharaohic circumcision. So it just depends on what language she uses. So in this case scenario, Amina says she's not sure, actually. She's not sure whether she's had it, but she would like to know a little bit more. So then we need to start thinking, how would you determine the type or that she has? Because that has implications in itself, depending on the type and depending on the procedure. So we're in a maternity setting, eventually she's going to have a baby. I need to know, does she have type 3 and possibly will need defibrillation? Does she have type 2 where there's quite a bit of scarring and therefore it's going to be, the perineum may, there's an increased risk of her having perineal trauma during childbirth. If we're going to be using, she needs an indwelling catheter, for example, is that going to be a difficult examination or a difficult procedure? So all those sorts of things, we need to understand the type and the extent of the trauma that she has experienced. So you have identified, you're not sure, but she would like to know what type of FGMC she has. Now, going back one step is about, let's just say she says no, she doesn't think that she has FGMC or her community doesn't practice it. Another thing that you can do is talk about symptoms. So earlier on in that first part, I talk about her having painful intercourse, and it's been ongoing for some time. She's quite young, like why is she having painful intercourse? Then you can start talking about other symptoms. Is she having issues with recurrent UTIs? What other pain does she have? What is her menstrual flow like? So we're not focusing on the FGM, we're actually looking at the whole picture. What else is going on that could indicate she could have FGMC? In this case, Amina has said she wants to know and she has consented to a physical examination. Now, be aware that physical examinations are not necessary. If the woman doesn't want to, it doesn't need to happen. So it's only if she requests it or she consents to have that done, okay? Because there are other ways that we can actually determine the type that she has. So the first thing will be, if you are doing a visual assessment, is that we need to identify all the structures around the vulva. So there are, as we have heard, there are 4 different types. Type 1 being that mostly the clitoris or the clitoral hood is involved. Type 2 is type 1 plus or minus the removal of the labia minora and the labia majora. And then type 3 is most of the time all the structures are cut, and then there's like an apposition of the tissue with a much smaller vaginal introitus. Sometimes in type 3, even though that section is sutured, you may still have a external clitoral gland there. So we need to be very careful when we're doing defibrillation because of that. That may still be intact. What I always say to clinicians is start at the top. Often in that gynecological and midwifery space, we sort of focus on the vaginal opening, and then we forget that there's all these other structures around the vulva. So really important, start from the top, and that will tell you what type the woman has. If the woman says, no, I don't want you looking, which she has a right to, then you can use visual tools with her consent. And there are various resources around. Here in South Australia, we've just been given a grant to develop our very own resources to go with the SAFE program. And there are various around, so you can, the WHO has one, New South Wales and Western Australia also have one. However, be very careful with this because a lot of the times women don't respond well to these diagrams. They don't understand what they're seeing. Sometimes they find them confronting. So please make sure that you have those discussions with women to determine exactly, if she's happy with them, and just monitor you know, how she's feeling about it before you just launch into showing her things that she might not necessarily be comfortable with. So for Amina, for our case study, I'm about to show an actual photograph of FGMC. And this is an image that I have been given permission to use. So please note that it is sensitive. So if you don't want to look at it, you can turn around or step away for a few minutes. So on examination, this is what you see. So as I mentioned before, we need to have a look at what are we dealing with. So in this case, if you have a look, we're looking at the clitoral hood. Part of it, it looks like there's a bit of scarring around the clitoris. That looks like the clitoral hood has been cut. Part of the external clitoral gland has also been cut. Also, the labia minora has been excised, so has been removed as well. There is no suturing around, and there's a little bit of scarring that you can see from where the labia has been removed, and it's partly, labia minora is still partly in this section. So according to the classification, this will be type 2. So this is type 2 FGMC. We can still see all the other structures, but there is some tissue damage around the clitoris and the labia. So you identify she has type 2. So what do you need to think about when you're having these discussions with Amina, and what is your management plan? And this is really important because a lot of the time women who don't know that they've had it all of a sudden have been told, yes, you do have it, and this is the type. That is quite confronting and quite traumatic. And a lot of the time also women go through a grief because they've lost something quite significant, and they have to now manage and deal with all those things. So this time is about having a conversation, making them feel as comfortable as possible, offering referral services if they would like to speak to someone, ideally a psychosexual counselor who has experience in FGMC. It's really important. Maybe having another appointment with yourself if you're the FGMC expert in your area, maybe having another debrief conversation, involving biocultural workers with obviously with the consent and permission of the woman if she wants to have someone else support her, having these conversations and giving the opportunity for the woman to ask questions and to also be involved in her care. So in this case, because she's having a baby, we're going to create a care plan for her in conversation. So we need to be aware that, as I mentioned earlier, women with, depending on the type and the extent of the trauma, are increased risk of perineal traumas in childbirth. So this is something that we'll need to allow for management in childbirth. So it will be something that other clinicians, especially her delivery suite or labor ward midwife, to be aware of and to be able to help her in childbirth and hopefully minimize perineal trauma. So the role of healthcare providers, so the main thing is things that we need to remember: women may avoid or delay seeking medical support for various reasons. It could be that they don't have Medicare, so they can't afford to go and seek medical support. She may be quite embarrassed. I had a woman that I interviewed who had a marina inserted at one point, and she was bleeding for 3 months and didn't go to the GP because she was really embarrassed because she was bleeding, rather than actually understanding that that is a significant issue and she needed to go to get help for. But she didn't want to because she thought it was something that she had done rather than actually, well, it's the procedure. Every contact with a woman or girl is an opportunity to identify her health and also cultural needs in terms of her care and provide her with the necessary information to make informed choices. So this is about including women at all stages of her care. Also understanding cultural competence. It's really important that we understand this is a set of behaviors, attitudes, and policies that come together to enable a system or agency to work effectively in cross-cultural situations. So we need to be able to provide women with access to the appropriate interpreter if the woman requires it, or if you've got a bicultural worker or FARREP workers, please include them. They're a great resource and very important, and they support women. FGMC in a clinical practice, it can be a multidisciplinary teamwork, and it's about ensuring that the woman knows that she has the support, as much as support as we can provide her, to ensure the best outcomes for her. Also understanding that not all women are the same. So, you know, you might have two women with type 2 FGMC, but they have very different and unique needs. So make sure that whatever care you're providing is individualized. A woman's country of birth or family's cultural background is a stronger risk factor for FGMC. Here in South Australia, we have added a screening question for FGMC in our pregnancy records. So all women, regardless of their background, are actually asked whether they have experienced this. And that is part of the conversations that we have. Again, a lot of the time, women do not know that they have FGMC, but there may be some symptoms that could give us a clue around that. And identifying FGMC early, especially in that pregnancy continuum. Other considerations, as I've mentioned before, it's important if we can have a lot more female healthcare providers for these women, because that's a respectful thing and it also gives them choice. Bicultural workers, essential. So if you have access to them, please use them. And continuity of care models is really important as well. So this is just a summary. We've just gone through all that already. Just to let you know, we have the South Australian FGM education program here. It's a 2-hour education. Part of 1 hour is a self-directive online learning that you do yourself. And then the other one is an interactive workshop where we actually go through a case study, and then you have the opportunity to ask questions, to practice these conversations in a lot more detail. So if you are interested, please let me know, send me an email, and I can get you started with it. So thank you.
Thank you, Monica. Thank you, Monica, for those practical insights. Also for that very comprehensive and informed case study that really brings the theory into practice. I think you touched on something really important in your presentation, and that is the fact that conversations about FGMC can be deeply sensitive and emotionally complex for women and girls. Also for health professionals who are supporting them. So I think it's an important reminder for all of us that while we strive to provide that trauma-informed care and compassionate care, health workers also need opportunities to debrief, which you touched on, reflect, and also look after their own well-being when engaging in this work, because it is a very sensitive but also traumatizing conversation to have, especially for women and girls. I think one of the consistent themes that I'm reflecting on across the presentations from all the guest speakers today has been the importance of language. And I really want to hone in on this because the words that we use in this space matter greatly. Conversations should always be guided by women's preferred terminology in language in ways that feel respectful, safe, and non-judgmental. So I want to thank you, Monica, again for sharing those resources that you shared in your presentation, and we'll make them available when we share the recording of the webinar as well. So now we have a short 10 minutes for a Q&A session with our guest speakers. I will start with the first question is directed to you, Juliana. And the question is, firstly, thanking you for your acknowledgement that FGMC is not just an African issue. So the question is, how do we respond when type 4 FGMC is dismissed as not so harmful and considered and not considered to have any long-term consequences? How do we respond to communities that might approach FGMC in that way?
I think I made it very clear in my presentation that we take our cue from the World Health Organization, and that the World Health Organization has said that all forms of types of FGM are FGM, and that reverting to minimizing one type from others and looking at the others as more dangerous than ours is actually quite discriminatory. So on that side, we talk about that. But I would leave the clinical aspect to Monica because she's got the clinical experience. But it's very important to understand that all types of FGMC have got their long-term effects. And it's about the clinician having that conversation with the participant on board at the time. One of the clinicians that we overlook are the child health clinician. And also, because if we work with the women, if you're in maternity and you've been working with the women from antenatal through birthing, one of the critical points is to look at what happens if that mother who you've been supporting has a daughter. If that mother births a daughter, then that also opens a whole heap of areas for conversation. Your psychosocial counselor comes in, your nurse comes in, your midwife comes in, and the child health worker will need also to come in. Because for some communities, first day to eighth day of the birth of the daughter is very important. And those are probably some of the communities that we don't pay attention to. So whichever type it is, the world is saying none can be condoned. If you think there are no side effects, you have a conversation about what is happening for you with your clinician. I think that's where I leave it.
Yeah, thank you. Thank you, Juliana. Yeah, and I do think it is up to that very direct conversation between the clinician and the woman about actually exploring, okay, these are the potential health effects that could come even with type 4. So
can I just add something? Sorry.
Yes.
Yeah. So I can add to it also the psychological effect of type 4 that's happened to the woman. So we need to pay attention to, it's not just the physical. I know it will be physical. I'm not expert in clinician, but we need to be mindful for the psychological effect as well.
Yes, exactly. That's part of the health impact
for the type,
one that is not discussed often enough and nearly enough. So yeah, I completely agree with you, Intesar. And Monica talked about, psychosexual therapy and how important that is, because we often look at FGMC in this lens of antenatal, postnatal support, but actually, what about women's sexual needs and their mental health needs that, affects women across all types of FGMC. So thank you for that, Intesar. We've got a question for Monica. So Monica, you touched on, you went through that case study and you talked about the importance of, firstly, ascertaining if the woman has had any type of traditional cutting and then how to ask the question. I want to know from you, how important do you think it is for health professionals to understand the reasons why FGMC was practiced? And do you think that actually informs their clinical practice in any way to have those conversations about the why, like why have you been cut?
It's up to the woman. I don't think I don't think it impacts the care that we provide or what we're going to be doing in, our case management sort of thing. I think if the woman wants to have those conversations, then that it's completely up to her. But I think as clinicians, we need to be focused on what do we have, like the practical implications of the practice. So regardless of the type that it is, we need to know, is this going to impact the care? Does she need referral to a physiotherapist? In the case study, this woman has had painful intercourse for a long time. She's got type 2. What else is happening around there? Is there sort of nerve damage or, something else going on? So I think as clinicians, we need to focus on those practical things. And it's not necessary to know why she's practicing it. I don't even think, unless there's sort of some safeguarding, indications that maybe the child or the baby might be a risk of FGMC, but that's a different conversation regarding safeguarding practices.
Yeah, thank you, Monica. Now I've got one question for all the guest speakers, and we've only got a couple of minutes, so I'm going to ask you to keep your responses to 30 seconds or 1 minute. So I want to know from all of you, for health professionals who may feel nervous or worried about offending someone, what is one practical piece of advice that you would give about starting the conversation about FGMC? So maybe we can start with Juliana.
I wonder why you're starting with me. I think we should start with Monica because she's in the clinician space, and then I'll answer your question. I think the issue of discomfort from the clinician is one that Monica has touched on. If you are providing clinical support, your discomfort needs to be something you deal with yourself. And if you're uncomfortable, you've got to educate yourself before you confront the person. And remember, discomfort is always on the face. And that is something that can shift a woman away from engaging with you. FGMC is like any other health issue. You're a clinician, you're faced with a health issue. You might say to the person, I'm not fully aware of this. I would need support. That's when you reach out to other clinicians or your FARREP worker or whatever. But don't take it upon yourself as, oh my God, look at what these people. This was the 1990s that we were talking about. Yeah. But we've changed now. We've gone so far. Thank you.
Thank you, Juliana. Intesar?
Yep. So similar to Juliana, just educate yourself. There is a really great video that's CoHealth's made. I really recommend you guys to look at it, how to ask the question or how to start the conversation. So it's all about understanding and respectful. And, so those kind of practices didn't happen because the woman wants it to happen. It's happened because there's a lot of other stuff that this woman has to do it. So yes, yeah. Start the conversation is really good video.
Thank you. And we'll make sure to share that as well when we share the webinar recording. Thank you, Intesar. Monica?
Thank you. I think it's about individualizing care. It's really important that as clinicians, we know that every woman is unique and therefore their experiences are unique. So we can't be putting on our sort of ideas and values and things like that onto their care. So if the woman, if you have two women with, for example, type 2 FGMC, that doesn't necessarily mean that their needs are the same. So you need to individualize care and never assume. Really important. Always have those discussions with women. Learn from women. They're the best guide for you. If you're ever unsure, ask her. She'll be able to give you that information.
Thank you. Thanks, Monica. So I think we've got about 10 minutes. So just bear with me for a second while I just bring up our closing slides. So we've come to the close of today's webinar. Unfortunately for me, because I was having a lot of fun, actually, just hearing from our amazing guest speakers. But I do want to sincerely thank all of our guest speakers for sharing their time, expertise, and reflections with us today. Thank you to Juliana Nkrumah, Intesar, and Monica Diaz for such thoughtful and insightful presentations. I also wanted to thank everyone who's joining us here today, firstly for your participation. It's really encouraging to see so many health professionals actually committed to strengthening their understanding in this practice, and that's really all that we can ask for. Before you leave, we would appreciate it if you could take a few minutes to complete the evaluation form, which will be posted in the chat. We will be also sharing the recorded webinar and all the resources that were shared by the guest speakers with you all via the follow-up email that we sent you. And we encourage you to circulate that with your networks. But finally, we also want to warmly encourage you to join the SWIFT network. So that is an online network for health professionals working in FGMC prevention and response. The registration link will be posted in the chat, but I'll also send it by email. This online platform is where we're going to be sharing information about our upcoming training opportunities, as well as resources related to FGMC healthcare, and not just resources produced by MCWH, but resources produced across Australia and internationally. So it's a place for all of us to actually just stay connected on what the new evidence is showing us, and also what's happening globally and what's happening nationally in the FGMC space. Thank you again, everyone, for your participation and contribution to this conversation. We hope the session has provided some useful reflections and practical insights, but I know that this, for a lot of people, is just scratching the surface. So please keep being curious, keep learning, and please reach out to any of us, MCWH, or any of our guest speakers if you want to learn more, or if you want to share what initiatives are happening in your workplace with us, because I think we need to create that learning environment so that, you know, as Juliana was saying, there's a lot that we're doing to advance the FGMC response in Australia, but there's also a lot of ways that we're falling behind in Australia. So let's catch up and let's do better. So I will close now. Take care and enjoy the rest of your day. Thank you, everyone.